So welcome everyone. I'm Jen Powell with the Delta Center California team, and we're absolutely thrilled to have everyone here today, in particular because we have both our learning laboratory teams and our state roundtable members here today. So we'll go ahead and get started with our agenda for today. And I believe someone's going to pop that up, and I'm going to go ahead and get started on that. So our title for today's session is Building and Sustaining a Diverse and Representative Integrated Workforce. And there's so much to that. And we are very excited to hear from three panelists today, who I'll introduce to you in a second, where we're going to have quite a bit of time to hear from them, their stories and experiences, with time for question and answers. And then we'll take a quick stretch break with a little more music, and then move into small breakout rooms. We're going to go relatively small rooms so that you all will really have time to interact between the state roundtable and the learning laboratory teams. So we'll tell you a little bit more about that later in the program, and then we'll wrap up promptly in 90 minutes. Our learning objectives for today, we have three of them. The first is really around, kind of tactical strategies that we hope you can walk away with today and think about around recruiting, retaining, and promoting BIPOC staff at all levels of integrated care. The second one is around advancing integrated care systems that value lived experience. And as you all know, that the equity and the lived experience, we are trying to thread into all aspects of integrated behavioral health and primary care. And certainly that's true with the workforce, and how do we think about that? And then third, unique to this virtual learning event, is learning and sharing across the state roundtable and learning laboratory teams. So we thought we'd do a bit of level setting, knowing that we can't really do justice to this complex topic of workforce, but we didn't want to take too much time on talking about workforce. We really wanted to spend more of the time hearing from our panelists and having you all think about some of the challenges and strategies that you have tested or think about from a policy perspective. So this is just a brief level setting slide here. When we think about continuum today in particular, we have asked our speakers to talk about either aspects of education in the pipeline, kind of who are you bringing into the future pipeline, and then the more typical things that you think about around recruitment and training. Retention, examples of what we mean with retention might include creating an environment that supports all types of workers, or including a living wage to create a sustainable work situation. And then we also really wanted to broaden that continuum to career pathways. What brings joy to the workplace? What really allows you to think about pathways for all the type of workers? And as we started thinking about the integrated care team members, and this was the list we came up with, and we certainly know it's not exhaustive, but it's so striking, the range of workforce in an integrated primary care behavioral health setting, no matter how that care model has been set up in a system that you would be utilizing people with very different levels of education and experience and background. So that is what we put together, and our panelists have programs, systems, and stories regarding how to recruit, train, and retain a diverse workforce in integrated behavioral health primary care settings. So we think we'll touch on quite a bit of this today in what you'll hear from the panelists and what we bring up in the breakout rooms. So with that, I'd like to introduce the panelists. First of all, we have Alfonso Apu from San Joaquin County. He's the Director of Behavioral Health of Community Medical Centers. That is a federally qualified health center or number of centers. Neera Singh is from Santa Clara County, representing the Asian Americans for Community Involvement, otherwise known as AACI. We're very excited to have these two external panelists with us today. And then we have Eleanor Castillo-Sumi That name and face may be familiar to you. She's the Vice President of Research and Program Development with Uplift Family Services. They represent, their clients represent Santa Clara County. And she's a member of the Learning Lab Team Eagles with two of the primary care lifelong and access health centers. So we're really looking forward to hearing from one of our Learning Laboratory team members as part of the panelists. With that, I'm going to turn it over to Robin, Robin Holler, who will moderate our panelist discussion.
Hey everyone. While we're getting situated, just one clarification about Eleanor is part of Team Eagles, which is Uplift and the Santa Clara School Health Centers and Pacific Clinics. And
oh, I'm sorry.
No, that's okay. I mean, there's so much to keep track of, but just so we put Eleanor in the right place in our orbit. And we are going to dive in. Thank you so much to our three panelists for joining us today. We're really excited to hear from you. And as Jen said, there's so much that we could talk about in this under this kind of umbrella, but we'll see where this panel conversation takes us and then give you all a chance to continue that conversation in breakout rooms. And we will have some time at the end of the panel for questions from you all. So feel free to chat those in as we go along or be ready to ask your questions to our panelists at the end. And to start with, I'm going to direct our first question to Alfonso. And that question is on recruiting. And what strategies do you use to recruit BIPOC staff and or providers with lived experience?
Thank you, Julia, for the question, and thank you for having me here. It's certainly a pleasure. I do apologize. I'm in a rental car from an airport. Okay, so I hope that I can give you enough information. In reality, our journey towards hiring folks or employees with lived experience really started about 2 to 3 years ago. I do want to say that before anything starts, there needs to be a shift in terms of how administration thinks about hiring folks with lived experience, and also how your HR department also conducts policy and hiring procedures to hire folks with lived experience. But we started with a very small grant. It's what we call our Transitions Clinics Network Grant. And this grant essentially offers integrated care management services to individuals being released from incarceration, primarily state prison. So part of the requirement of this grant was to hire 2 community health workers with lived experience. So in reality, we had to shift not only in terms of our hiring process, but our policy, our interview, our how we supervise, because this was the first time we were hiring folks truly that their main criteria was lived experience. At this time, we have 4 community health workers that in total, they also have been released and have spent a total of a combined 40 years between all of them. So they bring a magnitude of experience to their community health worker roles. As we kind of shifted and were able to hire, we felt comfortable. We primarily did it as we were starting to have conversations, especially 2 to 3 years ago, about these issues of equity and inclusivity, not necessarily for just our staff, but our community. One of the things that I hear the most as I'm one of the team members that kind of hears complaints, patient complaints, is patients saying that our staff does not reflect the community, or it does not reflect them, who you're talking to. So we've really made strides to do a lot of kind of reaching out to the community in terms of education, in terms of setting up workflows, in terms of making sure that that patients are aware about what CMC truly does, and eventually in the community, this workforce development. So as I kind of hurry through this, sorry about that. I'm sorry about that. The
No
phone,
problem.
it's humid here in Miami, okay?
No problem. We so appreciate you.
Yeah,
doing that. Go ahead.
you know, as we shift and we look at workforce development, we've been able to generate some funding through some grants to be able to fund some of this staff to return to school, to get not only their bachelor's degree, but also their master's in social work. So at this time, 2 of these 4 individuals are going after their bachelor's, and the other 2 are graduating next month with their master's degree in social work. In turn, they've agreed to stay with CMC as they shift towards getting their license in social work. So I think in summary, we kind of shifted our culture in terms of understanding that our staff had to reflect our community. We engaged our staff. We looked at who we were serving, and we opened the doors for opportunities to interview by shifting our hiring process, our qualification process, which at times participants did not meet those qualifications. As we shifted those, we started getting a lot of input and a lot of interest from folks that we would have ordinarily not hired in the past due to their lived experience. And I am talking about TCN because the main focus was having a history of lived experience in terms of incarceration. What we're seeing with this is that this program right now has 160 individuals that are getting integrated care coordination. And the main reason we have 160 is not because we have an amazing workflow out there and because we're reaching all the prisons, is because folks that are incarcerated know our staff. And they actually reach out to them and let them know that they'll be coming out soon, that they heard about their services, and that they're really interested in engaging for services. So I think we've seen this kind of trajectory from us buying into and shifting our culture to allowing folks to interview and kind of hiring folks that we normally would not hire. And then looking at the product in that their lived experience has truly not only brought in patients, but has kind of developed this culture within our system that that we are inclusive, that we truly serve the community. So so I think that's just a brief example in terms of how we started hiring folks with lived experience.
Thank you so much. What a great example of how funding and kind of HR processes can really help drive change and transformation, and also, of course, of the value of having staff and providers with lived experience. Thank you so much for that example.
No problem.
I'm going to pass it to Eleanor now with a question around training. And Eleanor, if you could describe one effective strategy that you all have implemented to advance training and career progression for BIPOC staff.
So in my response, I just have to acknowledge Pacific Clinics, who is our partner in this Delta Lab and our partner within the Certified Community Behavioral Health Clinic and the school health clinics. Just a little bit of background why this is really important. All 3 organizations in Santa Clara, about 85% of the people that we serve are people of color. Likewise, in the school health clinics, 65% of the population there do not speak English, primarily Spanish. And we have the same similar demographics for Pacific Clinics. So the workforce that we bring in is really critical, and we think it starts with recruitment. Recruiting from some associations, including the National Association of Black Counselors, the National Latinx Psychological Association, Asian American Psychological Association, National Association of Black Social Worker, National Association of Puerto Rican and Hispanic Social Workers. So really working with these organizations to identify people, who are already interested in the field, and bring them into our organizations. Our partner in all of this, Pacific Clinics, they have a site in their LA, in Pasadena, or their MFT programs focus specifically, have specialties, I'm sorry, which draws BIPOC and LGBTQIA plus students. They include African American family studies, Latinx family studies, and LGBTQIA plus studies. So developing, these particular programs that would draw people who are interested in the field and who can identify with these groups is a good way to really recruit people. One of the things that we've done at Uplift as part of our trainings, and so it doesn't end with recruitment, bringing them into management positions, people of color into management positions is really critical. And one of the things that we do for our managers at Uplift is have a training, and this is pre-COVID, we'll resume this once, we get past this pandemic, but we train all our managers. Part of the trainings include Posner's, 5 exemplary leadership skills. And as part of that process, they get to choose an accountability partner. So an accountability partner that helps them in their leadership development. I personally have trained a number of, or been an accountability partner, and it goes both ways. So this is not just as a mentor-mentee relationship. It goes, broader than that. But one person was a person of color, male, who was really looking to develop his skills and his leadership skills and really develop his pathway within the organization. And that discussion transformed from, not just within the organization, but any other mental health organization. How can you develop yourself as a person of color to become leaders in this field? Another person, you deal with intersectional issues. Another person that I personally have mentored, again, a woman of color, a mid-level manager who's also pregnant, so dealing with motherhood, dealing with, where you are in your 30s, wanting to become a leader and needing to potentially pause your life, to become a mother and, to deal with all of those roles. So, this accountability partnership allows people to kind of have that partner that's different from a supervisor, that's different from a coach, that's different from a friend, but someone that can hold, where we can hold each other accountable to develop ourselves as individuals and leaders within the field.
Gosh, how nice to have that support. I identify with the position that person is in. I think probably a lot of us can in some way or another. What a great resource to have that kind of support. Thanks for sharing that with us. Now I'll turn it to Neera and ask about retention. What is one challenge that you have faced retaining staff with lived experience, and one strategy you've used to address that?
Thank you, Robin, and really appreciate the opportunity to be a part of this conversation. And it's nice to see some familiar faces and esteemed colleagues. I definitely would say, of course, competitive pay. And we know that there's really a lack of bilingual, bicultural providers of any discipline, but especially for these positions, and especially in the Bay Area where folks can make more doing other things. But a bigger one that I'm going to focus on really currently that we're dealing with is really preventing burnout and addressing compassion fatigue and vicarious trauma. I mean, around pay, of course, we're working on competitive salaries and advocacy, but also it's important that we're providing flexibility, training, mentoring, and opportunities for internal advancement and growth that, my colleagues have discussed. And, we've started as early as high school, and have our, master's level and doctorate level trainees, and we're an APA accredited internship program. And also those opportunities for mentoring, that Eleanor just shared, and seeing that there's a place to grow within the agency too, is really important. Around preventing burnout and compassion fatigue and vicarious trauma, really making sure that we have individual supervision as well as group supervision for peer providers, providing both consistently, weekly, and making sure that we're supporting folks to identify and process countertransference, as well as having case conference opportunities to address parallel process and power dynamics that come up necessarily in a multidisciplinary team approach to care, that we have, and, having trainings on vicarious trauma as well as vicarious resilience is really important. And so is having, process groups and listening circles and resources for self-care and wellness. We were really fortunate, ECHO was really fortunate to have a grant from the 1440 Foundation to train all staff from the front desk through executive leadership by Dr. Lynn Waldy from Palo Alto University. And we've created a space that we call the Lotus Room that folks can reserve to practice mindfulness or whatever self-care. We do regular self-care assessments and plans every 6 months. And our HR team has been really amazing in terms of tapping into a variety of wellness initiatives around nutrition, exercise, mindfulness, and fun. We just finished our Walktober challenge. And this November, we're doing a 12-day Road to Resilience challenge. The other thing that we've really been looking at is adding opportunities for more civil engagement and advocacy, which is, empowering, and it's such an important part of whole health. And then also just making sure that we have resources, our EAP program, making sure folks are connecting to frontline worker mental health resources. And we're really actively looking into other ways we can really support behavioral health care.
Thank you. When we spoke previously, that power dynamic sort of challenge really stuck with me, and it's something I definitely took away from our first conversation. And we're going to kind of move into time when we welcome interaction and conversation from you panelists with each other. And so maybe I'll use that as a good opportunity to see if Alfonso or Eleanor, if you have anything to add around that, kind of like, how do you navigate the power dynamics, both of different provider types, but also as you're thinking about integrating primary care and behavioral health?
Well, I can speak a little bit in terms of the program that I mentioned, as our entire system was not only new to hiring candidates with previous lived experience, especially incarceration, but also seeing and providing services to patients who were truly identified as being recently released, and the issues that come in when treating those patients. As we know, patients who are incarcerated may not get all the services or the level of services that they require, especially for behavioral health and, of course, physical and SUD. So as they come out and are in need of services, they present with a gamut of issues that our staff needed training, needed to understand how to navigate those relationships with these patients, and also navigate those relationships with the currently recently hired staff, because even though the staff are, of course, free to disclose anything about their past, and they tend to be very transparent and say, this is who I am, and this is who I was, and these are my skills now, and these are my patients, and I have lived their life, and I can help you in terms of helping them. So so that's where those power dynamics and differentials really come into play for us.
I would build on what Alfonso said in terms of, we have family partners, we have, peer partners for our adult services. And I think it's important to acknowledge, explicitly acknowledge that there is a power differential. And that kind of, just that honesty and recognizing that, opens up the conversation a little bit. So you have these relationships, it's, between the provider and the consumer. And as Alfonso said, and we likewise have, the same thing where we've hired people with lived experience, again, family partners or peer partners, to help navigate that, to help build that trust, to help facilitate those, those conversations. And there's also power dynamics within the organization, right? I mean, even though you want staff to be open and honest with you, there are power dynamics. I mean, and we cannot ignore that. But I think creating a culture regardless of whether it's between the provider and consumers or within the organization, one of the values that we have as an organization is creating a welcoming environment. And that means welcoming in every sense of the word. Welcoming so that you, if you're someone of a different culture, feels welcome there, whether it's ethnic, gender identity, whatever the case might be. But if we have this basic principle of having a welcoming environment, I think that's then a driving, one of the driving forces in helping to navigate those difficult conversations.
Yeah, I so agree. It's so imperative, right, that we create this environment where we're nurturing that everyone feels valued and respected. And, that we do this with everyone, and that they're all, in terms of the team, multidisciplinary team, they're all contributing as an important part of the care team, with our client at the center leading the care plan, right? And I think what I was also alluding to before is like, given we're serving a very underserved and marginalized community members, that we should expect some parallel process, right? I know it's a very psychodynamic concept, but to emerge with multidisciplinary teams. And so having support to be able to have those difficult discussions and identify when these things are coming up, I think is really, really important.
Thank you so much. As we're thinking, for this group about behavioral health and primary care integration, are there other challenges that you all have faced in trying to develop and support teams or staff that provide integrated care? And do you have approaches that you've taken to address or overcome those challenges?
I'll start. I mean, we definitely have, those challenges. But I think we all start from the same premise of understanding that we're operating from different cultures. We work with, school health clinics. There are primary care and FQHC setting. There's a different thinking around that. We're in a, mental health space that has contracts with counties. We have a different way about thinking things, but what we do have in common is this common understanding that we have this forum where we can address those things. So we would have implementation meetings where cultural issues do come up. And so together as a team, coming from our own, lens, recognizing that there is a different way to do things has been, it's challenging, but it's also a place where we can kind of work through those things. We have, MDs, and then we have psychiatrists, and then we have, system navigators, and everyone plays a critical role. And I think, but again, explicitly acknowledging that we're coming from different places, even though our mission and our goals are the same, is really important. Because then it's not, that person is not listening to me, that person is being rude, that person is doing things wrong. But that we're coming from a different place, and we all have the same intentions and the same goals.
For us, what I've noticed also just logistically during the pandemic, it was just really hard. I mean, we've been working towards this true integration, and with our health center folks all being on site versus our behavioral health folks being able to be more flexible and be remote, I think there were just logistical challenges and like how, all the things that we've all been dealing with, and how do you build team and how do you build those opportunities? A warm handoff looks a little bit different, right, in these spaces. And so I think it's just really been also, being flexible and problem solving around how we're able to really do true coordination and collaboration.
At least for us, certainly access is always an issue, especially with the last year and a half, not only working remotely, but also at the centers, and the demand for more behavioral health and SUD, and also kind of shifting into that realm where, as an FQHC, us needing to focus or being assigned to the mild to moderate folks with mental health and SUD issues, but that system being very nebulous, especially as there's more need for behavioral health. So we are certainly seeing a lot more patients that would be deemed severe, that would meet criteria for a higher level of care. However, due to access issues in different systems, we've had to shift in terms of how we provide services, not only to the mild to moderate, but to the more complex patients, because we're seeing that we feel that integration does work, and that a patient that is severe and has mental health issues can see their primary care and see dental and just be overloaded with care coordination, because the alternative to that is that most likely they may not get too many services and they may get lost in the system. So that's kind of what we're seeing and navigating and providing support for our staff to be able to provide those services.
Mira, if I can go back to something you said, because I've heard it come up for our participants before, that the fact that in COVID times, the part of the staff is remote, behavioral health staff might be more remote, and the primary care staff is in person. Have you found ways to navigate that, or do you have nuggets that you could share for things that you found that worked well for kind of keeping cohesion or communication amongst your teams?
Yeah, it's just been like an ongoing process to find like the best way that works. You know, in some instances, we were able to find that the team was a little bit more accessible, even because they could jump into a Zoom, meeting and be available. And in other instances, just like making sure that we have at least somebody that's on site at some time, and having a hybrid approach so that the folks that really needed that face-to-face could get that support. We did, but I think it's still a work in progress as we're figuring it out and adjusting to what the needs are. But the support really makes a difference. I think the other piece is around resources for language as well. So, the fact that we also do have our patient navigators that are able to support, I think that makes a big difference in helping. But yeah, the engagement piece is really hard, and just also making sure that community members have access to resources to be able to connect with telehealth. And of course, I'm preaching to the choir. Folks are all dealing with this, and just making sure that we have resources for digital literacy, so we get to really leverage programs from our wellness department around digital literacy for folks as well, and yeah, just actively problem solving like everyone else is. I don't know if any major nuggets of wisdom there.
Eleanor, I saw you.
Yeah, I don't know if I can add anything either. Yeah, you're absolutely right, Nira. I mean, with this integrated health, we started, right at the beginning of COVID. So we started a new program that required integration. We're introducing a whole new bunch of staff to the primary care setting. When we all had to do this virtually. Those are not ideal circumstances to start an integrated program. But so to the extent that we can have, multiples, whatever, and at Zoom, we all cannot wait to get to be able to be in person together. I mean, I think that is an overwhelming sentiment. But we also likewise, as soon as we could go into be in person, to the extent that it's possible and reasonable and safe. Those are all things we're navigating, but as soon as we could be in person, we wanted to try to be in person. But meanwhile, we would have these multiple forums where different groups, different primary care physicians, whether it's, during the monthly QA meetings, whatever the case might be, just trainings, cross-functional trainings, where people can see each other via Zoom, but at least know that there are other bodies there and other expertise there that can help the larger team. That's as good as we figured out, I should say, at this point.
Alfonso, I'm happy to give you a chance if you have anything you want to add there.
No, I think the two ladies did it perfectly. I think we're just kind of shifting towards really the need of not only staff, but the need of the patient, right? Because during COVID, primarily, at least for behavioral health, 95% of our encounters were through telephone. And as we shifted, we started seeing more patients face-to-face. Patients started asking for more face-to-face. In our behavioral health department, I have approximately 28 clinicians, and most of them are have a kind of a part-time schedule, 2 days remote, 3 days in clinic. That really seems to balance this need of patients wanting to be seen face-to-face, and also patients who are comfortable with technology and enjoy video or rather have telephone calls. So we are still providing a good 70% of our encounters through either telephone or video, and both parties seem to be content in terms of staff and patients with this shift that has occurred due to COVID.
Yeah, I would want to add to that, Robin. You're absolutely right, Alfonso. I mean, this desire that we have to be in person is based on our experience of, being in the same space, bricks and mortar, right, pre-COVID. So we're comparing our current experience to that experience. But what I do think that we do need to figure out, just building on what Alfonso said, I think we will be dealing with a hybrid community in service delivery. There is going to be a mix of people who still want to do the Zoom calls or, a telehealth. We've had parents with autism say, I can now do parent training because I don't have to run from work to pick up my child, to get home, to get my other kids all set up. So the Zoom works for them. And I don't think, telehealth is going away. So I do think that it's going to be a paradigm shift, even for myself, but I think that we will be seeing more and more. I think it's us figuring out how do we do this in the hybrid world of a mix of telehealth and in-person, because, we don't have enough staff to be not going out to the homes. But, it's going to be, it is going to be a new way of doing business that I think we do need to figure out. So I don't think, even though we want to all be in person, I think that's going to really change. COVID has changed that.
If I may add to Eleanor's point also, and that certainly addresses the issue of barriers to treatment, right, and social determinants. I know that during COVID, our no-show rate just plummeted down, which was amazing in terms of having access to patients because phone was easier. But in turn, it certainly has some barriers, but in turn, it kind of addressed this traditional barriers of transportation, daycare, of just having more access to appointments at different times, people maybe not needing to get off of work earlier and taking a phone call. So that has certainly impacted our services. And as I mentioned to you, it's certainly helped us with our no-show rate. However, as we see more face-to-face, we're seeing those traditional barriers come back in terms of daycare and all those other social determinants.
Yeah, I would definitely agree. I mean, we saw a change immediately. We didn't necessarily see a change in, the the units that we were producing, but they were appearing differently. So less frequent, I mean, less in length of time, but more frequent. So instead of your hour service, it might be 30 minutes a week instead. But we did see a change in how service was being delivered and received.
Thank you. I want to make sure we have time for some questions from our participants. So if anyone has questions for any of the panelists, feel free to put them in the chat, or you can unmute yourself. Julia, I don't know if you want to take us off, go back to gallery view so we can all see each other. And we have a few minutes for any questions that you want to pose to the panelists before we go to our breakout rooms to continue the discussion. So feel free to unmute, or you can raise your hand if you want to.
Robin, I wanted to share, as we're just like a last thought around this, that, having the connection with the community and the experience of navigating the system is so key, and professionals with lived experience are so instrumental in supporting engagement and building relationships, and we all know that. And I, just before this came from a debriefing about national assessment of COVID and health parity for API community. And it's so important, going back to our history, I think, we were established to address the unmet needs of Southeast Asian refugees from Cambodia and Vietnam. And, we know finding bilingual, bicultural providers has always been an issue. And we, ACCI played a really key role in reversing the State Department of Mental Health directive that declared paraprofessionals ineligible to provide services. So, really supporting professionals with lived experiences is really ultimately about supporting health equity and parity. And just really wanted to make sure that we underline that. And I know, again, we're all on the same page about that, but thought it was really important to underline.
Thank you so much for elevating that. Really appreciate reminding us of that really important point. I see Samira has a hand raised, so I'll pass it to you, Samira.
Thank you. And thank you so much for that discussion. It was really great. I was curious, for those that are working with people with lived experience with the passing of SB 803, are any of your counties doing the peer certification process, and how is that going to change some of your workflows? Will it make it easier or more challenging since you're already working with people with lived experiences?
That's a good question. I think we're still kind of in limbo with that, because as you mentioned, we have hired folks with lived experience. They've been trained. This TCN model is actually a large model, and I believe there's about 20 states that have clinics that focus on hiring folks with lived experience, and there's a specific training. We're certainly excited about CalAIMS and how that's going to impact this population. However, we're still in limbo in terms of what's going to happen in terms of certification. From what I hear, that there's some push to maybe grandfather some of these folks that are working with this population already, but I don't know enough, and I apologize for that.
I know that when I used to work with Richmond Area Multi-Services in San Francisco, they developed a peer certificate program. I believe it was with UCSF. And actually at ACCI, we're looking into, either developing one or partnering. I think it's just so important to have avenues for the support, the training. But yeah, we're keeping an active eye on all of the all of what's going on, but this has been our ongoing. We've always had peer providers, and this is our ongoing commitment.
I'm gonna some of these questions might be great conversations for the breakout rooms. So because I think everyone in this room has, I'm sure, things to share on that point. I'm going to pass it to Fausto, who has the next raised hand.
Hi. Good morning. One of the things is I know that DCFS was starting to hire people with lived experience, especially their own foster youth. They were starting to hire within the department of in LA County, Department of Children and Family Services. They were training their foster youth, and they were hiring as well. And then some of them, they were providing them with training experience, which and also show them how to do a resume for them to get hired somewhere in the private sector. That was one. But my other, what I wanted to talk about was that, one point that you guys brought was about the limbo that we found ourselves right now due to COVID-19. One of the things, the experience that I have had, and I know, and I heard many of them, many therapists are having, is many of the clients are feeling abandoned. Not abandoned because we're not seeing them any longer or anything, especially for those that work with the Hispanic community, because some of them, they don't know how to use Zoom. Some of them, they have difficulty using or learning how to use Zoom. So some of them weren't able to be seen at that time. And due to that, they feel abandoned, especially the kids, because we no longer have that. Kids, they need that face-to-face therapy, and then and now it has changed to Zoom, and it seems difficult for them. Even classroom, I know I was asking my nieces and nephew how they're doing in classroom, the virtual classroom, and say they don't like it at all, because it says some of them, they don't. Sometimes I feel that they're not paying attention to me, or they're not, different things. So we have to think about that in regards to our clients, how to better serve them. How, even though we're in Zoom, how can we start serving them and start paying more attention to them? Because this is the reason why we are here, I think. And then regarding like as I was saying, many companies like DCFS, I know that they're starting to hire and they're starting to train. Maybe there's something else that we can also do within our community, and start to hire and start training these individuals and the jobs that they want to be in. So, thank you.
Thank you so much for sharing. And as I said, encourage these conversations to continue in our breakout room. I think we have time for one more question, which I'm sorry, Michelle, means we probably won't get to you, but Mia, if you want to have the last question for the group before we take a quick break.
Sure, thank you. So everybody, I think, kind of alluded to ways that they're supporting staff after they're hired. And people mentioned listening sessions, I don't know, like the Lotus Room and different things. And I'm wondering for you all, what have been the most effective ways that you found the most, just impactful when it comes to supporting staff in those types of forums?
Okay, I need you to bounce.
It's a great question. I mean, I think the biggest learning for us is that self-care is different for everyone. And so there isn't one way. So having a multifaceted approach is really important, because for one person, a Walktober challenge is wonderful because it's getting them moving. But for another person, the mindful, doing the self-care. So it's just having all of these different things and consistent supervision and opportunities so that folks can choose, and that we're not dictating what self-care and wellness looks like, just like we want that, just like the value that we have in how we serve the community, that there's not one path to that. So I think that it's really important to have a lot of different opportunities and to really ask the team, what is wellness for them? What is self-care for them?
I completely agree, Nira. And, one of the things, it's also, I would say in the beginning of COVID, there were a number of parents, that were thrown off now needing to be teachers. And we made it explicit to say, you know, I mean, I completely agree that we need to have multifaceted ways. And then as an organization, I think understanding who your staff are. And for us, that meant we have a lot of young parents or that had 3-4-year-olds and even younger that needed to navigate Zoom for school. So we made it a policy to not have our meetings start any sooner than 9 o'clock. You know, I mean, simple things like that, that just recognizes, you know, in the morning, it's a little hectic. We're not going to try to do any 8 o'clock a.m. meetings. And so if someone said, I cannot do it because I am helping my child get onto Zoom, that no one blinked an eye about, or, you know, passing, or no one would feel like judgment was being passed on them. So those are some examples of, I think for me as a parent in the beginning, that was really impactful. Just, you know, a simple thing like that for your staff. That was across all boards.
I would reiterate that. I think if I could sum it up in one word, it's just flexibility for our staff and understanding that just as hard as it is to have this influx of behavioral health access and need, our staff were going through the same process with COVID-19. So really providing opportunities for flexibility, whether you needed to do remote 4 days, or whether you rather come in 4 days, or whether you could work a 4-10, or you could work different schedules. We were really able to really look at all our staff and look at the needs of the patients, but also look at the needs of the staff. So being extremely flexible. And the other thing for us is really providing these opportunities for connectivity, and not necessarily for patients, for them to connect with patients, but for our staff to connect back to their care teams in one way or another, be it by being at the center, attending different meetings that included other care team members, just making sure that they were always connecting in one way or another, whether it was through Zoom, through telephone, or coming in for special meetings. And you know, I've been in meetings, especially with our behavioral health and SUD. We recently just had a large meeting where there was at least 30 of us there. And the one thing I heard the most is, oh, wow, I haven't seen you in a year. And it's just being here, it's great to see you and really seeing that joy. So flexibility and connectivity.
Thank you so much. Those will be our last words from our panel. And Alfonso and Nira won't be sticking with us, so just want to take a minute to say thank you so much for your insights and for being with us from your car in Miami, 3 time zones away. We're so grateful.